card that comes up.
Yep.
And it says invite participants, share screen.
And miss us here entirely.
Ah, now it's working.
Oh, good deal.
Don't forget to push the record and put it in the cloud, please.
Already done.
Awesome.
All right, let's, everybody ready to start, or are we still waiting a couple minutes for everybody? Is that Brenda, Tad, Roden, Greg, Jane, anybody else?
I think that's probably it. Oh, is Jeff there too?
Jeffrey, yeah, I see it, okay. All right, well, let's get started. Whoever joins us afterwards, more pleasure to them. Now, most of the time, this is an hour, hour and 10 minutes and such like that, but mesenteric ischemia, I'm driving home 1 point only. The next registry test coming up, the National Registry, has 2 questions on this mesenteric ischemia. And it's become a hot button topic because as patients age, they're going to start experiencing old persons type diseases. And one of the old person type diseases, which is one of the top 8 diagnoses that not only are causes of death, but also top 8 liability diagnoses, where mainly physicians get into real serious trouble when they can't die in a timely manner. Because as the name implies, mesenteric ischemia, mesentery, which means the entire small and large bowel, becomes ischemic and then infarcts. Now, we're going to cover mesenteric ischemia, but I think you're entitled to at least know the background on this. I working in the emergency department at a large level 3 regional medical center. We get a lot of EMS runs that come in, and one particular day, a 78-year-old female came in with quite a bit of abdominal pain, but when the paramedics pressed on her abdomen and such, they didn't find much. And so they kind of lollygagged in. They didn't start a line, didn't give her anything Zofran-wise or anything for the vomiting. And when they got her in, of course, we see the patient, and we took a little different tune to her. Not that the paramedics did anything wrong or that anything they would have done right or wrong would have changed the outcome. However, the fact that they missed it, they weren't even aware of it and such, was really disturbing to all of us. So the genesis of this particular presentation was twofold. Number one, I want to correct a real wrong that's out there when it comes to attitudes towards our old folks. And then second is, there are 2 questions on the next upcoming National Registry which talk about mesenteric ischemia. Now, what the actual questions are, I don't know. I can tell you that there's risk factors and then there's case scenarios. And so didactic question and answer where there's one best choice, or you can get it as a case scenario where you run through 3 questions on the case and finally come up with the diagnosis. Either way, by knowing mesenteric ischemia for this particular exam, you will know either that it is mesenteric ischemia or that in your mind you have ruled it out and therefore can eliminate that answer. So let's get into it. Much the same way that when you throw a clot from the heart and it comes back down the aorta into one of the little ostia openings for the left anterior descending artery at the base of the aorta, the clot slides down in there and you get an embolic myocardial infarction. Now, that's a little bit rare type of myocardial infarction where clot actually has to travel out of the heart and then get back into the heart. Most myocardial infarctions are caused by a thrombus or plaque that's inside, and then all of a sudden the plaque ruptures. That's a thrombotic. So in other words, it originates from the actual site. Embolic means that it originated at a site other than where it ends up, but it has to travel to that site. So for instance, what's the most famous example of embolic anything? Embolic strokes. The left atrium has clots in it because of atrial fibrillation. The clot travels through the left ventricle and up into the left of the right carotid artery, and then lodges in one of the large vessels there, causes a stroke. That's embolic. It's very rare that you would see, it's just the opposite of the heart. It'd be rarer to see a thrombotic stroke. In other words, type of stroke where there's plaque inside the cerebral artery where it ruptures and then suddenly blocks off the blood flow to that particular part of the brain. Subsequently, you get an interesting paradigm here is what constitutes embolic and thrombotic. Probably doesn't make much of a difference except to say this, that if your patient has any type of neurological deficits, abdominal pain, or even heart problems, and they're in atrial fibrillation, then you have to be thinking about embolic events. In other words, clots forming in the left atrium because of the atrial fibrillation traveling to the rest of the body. What happens with mesenteric ischemia is that the clot doesn't settle into the heart to cause an MI. It does not settle in the brain to cause a neurological event, in other words, a stroke. It instead travels around the ascending, transverse, and descending aorta, and gets down into the abdomen. And then you got 3 unpaired arteries coming off the aorta, and you got 3 paired arteries coming off the aorta. The biggest one is the superior mesenteric artery. And that's going to be the focus of our lecture tonight, is going to be how does that clot, you already know how the clot gets there, left atrium, left ventricle, around the aorta, down into the superior mesenteric artery, which is the second unpaired artery off the aorta. And as a result, it clots off blood delivery to the entire small bowel and 2/3 of the large bowel. And it's a pretty significant clot. So let's talk about a couple of facts real quick. As you see up on the screen, it's not common. It's only seen in about 1 in 1,000 people. But if your ER is seeing 50,000 people a year, you're going to see 5. If you are running in a busy EMS district, 1 out of every 1,000 calls that turn out to be abdominal pain are going to be mesenteric ischemia. So even though it's not a very common diagnosis, it's a killer. And you have to pay attention to the killers out there. Now, because of the aging population, arrhythmia and atherosclerosis, congestive heart failure, and all the other things that our older folks run into as they get into their golden years, you're going to start seeing a lot more of this. This incident could very well go up, with 20% of the population by 2020 being predicted to be over age 65 and utilizing well over 50% of the ambulance and EMS services that are out there. I can assure you, you're going to run into this a whole lot more. So your job is to recognize it, treat it as best you can, and hustle them into an emergency department where they have surgical capabilities in the hospital. Now, in spite of all the technological advances, the death rate from mesenteric ischemia today in 2017 is the same that it was in 1983. Despite CT scan, despite the D-dimers and some of the other blood tests that we have to help us develop these, and the EKGs and how fast they are to interpret, and then ultrasound and such, despite all these advances, we haven't made an impact on mortality. So our greatest asset right now, the best way that we can decrease the mortality rate is 1 person to 1 person, 1 paramedic to 1 patient. Be thinking about mesenteric ischemia, recognizing it early, and hustling them in with the diagnosis in your head. This looks like a mesenteric ischemia. We're going to go over a couple of things of what makes this mesenteric ischemia. I have a general statement up here that patients are vague, variable signs and symptoms, poorly localized abdominal pain, nausea, vomiting, diarrhea. Well, that's a big help. Let's see, that's probably about 30% of all my calls in the last 24-hour shift. So how do I tell the difference? Really, mesenteric ischemia is one of those diagnoses where you just have to be really alert for it. And if it smells like it, acts like it, walks and talks like it, it's probably going to be something close to it. In any event, these folks are going to get a CT scan. But by you coming in and using the words mesenteric ischemia, or I've got pain out of proportion to findings, or this patient's an AFib with abdominal pain, I'm worried about the bowel, what you do is you tune in the rest of the ER to the possibility that this diagnosis exists. And you can even write that down in reports. Hey, look, based on this, I think I've alerted the staff to the fact that this may be mesenteric ischemia, however, and then just take it from there. So sometimes we're not thinking in the emergency department, we just got slammed with 15, 16 ambulances in the last 2 hours and such. And when you come in and roll in and you say, hey, I got a sneaking suspicion for this, we're going to pay attention to that. We're going to really pay attention to it. And the life you save may be that patient's just by the fact that you spoke up. All right, we go to the next slide. And without, of course, a proper diagnosis of mesenteric ischemia, guess what? We've got a dead patient. I mean, it's just not going to hold up very well that the patient is going to do anything that's
Dr. Frame, can you hear me?
Yes, I can.
Yeah, we were hearing you and then everything stopped. Is there something going on that I need to fix?
Now, we've got a problem on the other end here. One of the slides jumped to a something different here, and then it cut out the audio. So I apologize for that.
Okay, no, that's a problem. I just wanted to see if there's something I needed to fix. Okay.
Nope, nothing to fix. Okay, so let's go to pre-hospital. So you're called to the scene of a 78-year-old female who's having abdominal pain. The patient has various risk factors, and let's talk about those right now. The first one is going to be what they call low flow state. The low flow state means exactly that, atrial fibrillation with low blood pressure. The patient's not pumping a whole lot of blood because of the atrial fibrillation. Of course, there's always ejection fraction issues and decrease in the ability of the heart to contract when you don't have that atrial kick. In other words, when you don't have that atrial beat moving the blood down real fast to the left ventricle and then out the body. When you lose that, you lose a lot. So you have a low flow state, and the low flow state also sets up what? Turbulence, blood flow in the left atrium, which sets up blood clots. So blood clot forms, and then all of a sudden the blood clot slips into the left ventricle when it becomes heavy enough, and then shoots out the left ventricle into the aorta. And next thing you know, you're shooting out emboli all over the place. Some can go up into the brain, some come back into the heart. Most of them just go all over the body and appear to be harmless. Every once in a while, one makes it all the way down to the leg, and you got yourself arterial occlusion with a cool, painful leg. That happens as well. But we're talking about the clot now that ends up in one of the unpaired arteries of the abdominal aorta, which is the superior mesenteric artery. So once it slips into that artery, it clots off the blood supply to the entire small bowel and 2/3 of the large bowel. Now, what kind of symptoms does that give you? Well, you already know it's an elderly patient. That's number one. As soon as you see that 75 plus pop up on your scenario with abdominal pain, be thinking mesenteric ischemia. Then they're going to throw in the atrial fibrillation. They're really going to start to tease you here a little bit. They're throwing a lot of big clues at you. So now we're at 75 or greater in a elderly patient with abdominal pain who now has atrial fibrillation. And those are three of the biggest risk factors going right now. If the patient's not on anticoagulants, say aspirin, Coumadin, such like that, that's going to be a relative risk factor, the fact that they're not being anticoagulated. If they have a history of cancer and such, you know that they're hypercoagulable. Cancer states set up blood clots. And so that would be another risk factor. But the three big ones, elderly, the atrial fibrillation, and the abdominal pain are the biggest ones going right now. Now, the most important action to consider is that this abdominal pain, the patients complain of excruciating abdominal pain, but when you put your hand on their abdomen, they're not really having that much pain. In other words, you're having difficulty trying to localize it. Ma'am, I've been in your left upper quadrant, your epigastric, right upper quadrant, both hypochondriac areas, left, right, the periumbilical area. I've been in the lower quadrants. I've been all over the place. And I can't seem to locate your pain. You know, she'll say it's diffuse, it's cramping, it's horrible pain. And she can't understand why you can't figure it out either. That's your first clue. Pain out of proportion to findings. That looks it's the patient's experiencing something much more painful. And yet, when you try to look for it, it's just not there. Now, one would say, well, it's a Chicken Little scream. It's a cry for help. It's an exaggerated response. So the patient's kind of a wimp. That kind of stuff. All that stuff has to go out of your head. Your prejudices and your biases have to go out of your head in favor of this patient may exactly be telling the truth. And she's trying to tell you that my pain out of proportion to your findings, you should be thinking mesenteric ischemia. So first thing you do, you have one of your EMTs throw them on a 4-lead, see what your rhythm is. You got an atrial fib, fine. Get the 12-lead going. You want to make sure they're not having some sort of ischemic or infarction. That's all fine too. But the bottom line is atrial fibrillation. Now, what happens after that? The patient starts releasing some acidosis. Whenever you infarct anything, you infarct the heart, it hurts. Infarct the legs, it really hurts. Cut up blood supply anyplace else, it hurts. Fortunately, the brain doesn't have pain receptors in the brain itself. It's all in the coverings of the brain and such like that. So fortunately, you don't feel the headache of a stroke unless you're experiencing some sort of brain bleed that's irritating the meninges. But in the case of the abdomen, there's a lot of pain fibers down there, as we are all aware of. And subsequently, any distension to the stomach or any decrease or lack of blood flow at all to the bowel is going to cause ischemic pain. And that pain is absolutely horrible. And this could very well, the pain itself can make the patient vasovagal. If not, if this has been going on for a little while and the patient's releasing a lot of lactic acid into the bloodstream, you're going to have a patient that's going to start going hypotensive on you. Now, what happens when you infarct the bowel? Well, the walls break down, and the bacteria, which were able to stay within the bowel, are now getting out into the bloodstream. And now you got a bacteremic patient, you got a septic patient. You may be even worse from a hypotension standpoint. And so these patients are going to require aggressive fluid administration, even if they're 78 years old. They're going to get a liter of fluids. Why? Because you have to keep the system tanked up. You got to keep the blood pressure up. The only hope of breaking that clot loose in any reasonable amount of time is to keep the pressure up, keep the patient well hydrated until they can get to interventional radiology lab where they can actually clot retrieve or inject streptokinase right into the artery and dissolve the clot right on the spot. So back to the classic presentation that you see up in the slide right now. It's going to be a patient older than 50 years old. I can tell you from experience and from the National Registry, they're not going to make it a 50-year-old. It's going to be 75 or more. Your more likely patient in the field is going to be 75 years or older. Sudden onset of abdominal pain. There may be nausea, vomiting, diarrhea. Well, okay, that's 50% of the patients you've seen in the last 24 hours. So nausea, vomiting, diarrhea is kind of cool when the symptom's present that you're thinking about mesenteric ischemia, but it's not a lot of value added here because there's only about 600 other things that can cause nausea, vomiting, and diarrhea. But the pain is going to be severe and out of proportion to findings. In other words, it's going to be diffuse and you're not going to be able to localize it. You're going to press all over the abdomen. It's not there. Pain out of proportion to findings. Be thinking about that at all times. Now, one of the more distinctive features of mesenteric ischemia is that the abdominal pain being out of proportion to findings is that there's not going to be any guarding or rebound. As you press in, they're not going to tighten up. And as you release, you're going to go, well, you're not guarding, you're not rebounding, and it's only nausea, vomiting, diarrhea, ma'am. Why don't you wait 24 hours and let's see what you look like tomorrow. If you're still having problems, give us a call back. We'll transport you to the hospital. Well, there'll be a transport the next day, but it'll probably be to the morgue. Because once they infarct their bowel and the bowel becomes infarcted at this age group, 93% of the patients will die within the first 24 hours. And of course, we all know that the longer you stay in the hospital, your mortality is going to go up. Ultimately, mesenteric ischemia, mesenteric infarction hits 100% mortality. There's no recovery from it. You can't cut out the bowel and say, okay, continue to live. It doesn't happen that way. Everybody loses. Now, what if they say, well, my diarrhea is starting to become bloody. I've had this pain for 24 hours. Now my diarrhea is bloody, stool is bloody. These are all questions that you're going to have to ask. They may give you that as a scenario. They may give you such a slap in the face, no kidding, this is the only thing that this could be scenario, that there's only one diagnosis here. And when they hit the 75-year-old patient with a pain out of proportion to findings, who's in atrial fibrillation, who's got a 70 pressure, who's at high risk for mesenteric ischemia, they may already be infarcted and now they're septic as well, and then you follow a sepsis protocol. But again, that abdominal exam and of course that, at least that 4-lead EKG, that 4-lead rhythm strip is going to be huge. Now, can patients with sinus rhythm have mesenteric ischemia? The answer is yes, under very limited certain circumstances, but now you're getting into 1 to 10,000, 1 to 30,000 patients, and quite frankly, that's not worth your time here right now. What is worth your time right now is the elderly patient with atrial fibrillation, having abdominal pain, nausea, vomiting, diarrhea, pain out of proportion to findings in atrial fib that would be consistent with mesenteric ischemia. All right. Now, the scenario that I just set for you is an embolus or a thrombosis. Embolized clots come from the left atrium and they travel around. Thrombosis sets up in the actual site. So right at the entry of the superior mesenteric artery, you may get a plaque that ruptures. Yeah, it happens, but you know, it's 50% of the time it comes from a clot that travels, and the other 50% of the time, and account for the other 7 categories, of which 3 categories you're more concerned with. But now you're getting into zebras and such. But the findings at least are going to be the same. At least you're going to have an opportunity to say, okay, this is mesenteric ischemia, and I'm not sure what causes thrombosis, embolus, whatever it is, venous, arterial, maybe even an SMA syndrome where the patient's had such weight loss that the bowel obstructs because the SMA artery starts to clot off the bowel and such. So there's a lot of things here. Your job is to recognize fluids, pain management, rapid transport to the hospital. So the embolus lodges distal to the origin of the middle colic artery, sparing the duodenum, proximal jejunum. These are all fun stuff that you want to maybe peruse if you're not doing anything like the other 1,000 things that you wish you were doing during the day. But if you run into an article where you're reading about mesenteric ischemia and you're reading about where the embolus actually goes, if it goes right to this top of the SMA, right at the origin, you're going to clot off the whole bowel and you're done. More times than not, it goes in a little bit deeper and clots off most of it, but still spares some of the bowel. So the deeper you get into the arteries, the better it is for the patient. The more distal you get, the less area that's going to infarct. And what they're talking about on this slide here is that the embolus that lodges at the origin of the middle colic artery, and that's something you may want to look up where that actual origin takes place. You'll see that you can spare some of the major portions of the bowel, and of course the duodenum and jejunum, and then the last 12 inches of the small bowel, the terminal ileum. Those are the 3 most important areas of the bowel. Now you could say, hey, Dr. Frame, the jejunum constitutes the other 20 feet of bowel. And the answer is that's correct. But the closer you are to the duodenum and the closer you are to the ileum, the more important the jejunum becomes. You can afford to lose a fair amount of bowel in the midsection there, probably about 6 of the 20 feet, and still be in pretty good shape the rest of your life. If you start losing areas close to the terminal ileum, or you start losing the areas towards the duodenum, and we got bigger problems. So how do you tell that in the field if it's a distal middle colic artery or if it's superior mesenteric artery? And the answer is you won't. And that's just the way medicine is. But you will still have the symptoms. And the symptoms are still going to be, in the 78-year-old person, atrial fibrillation. You're still going to have pain out of proportion to findings. Okay, so what other things can cause mesenteric ischemia? We got the arrhythmia. In other words, we got the atrial fibrillation, or any type of irregular rhythm that tends to form clots in the left atrium. What about the cancer patient who forms clots all over their body? What about the post-myocardial infarction patient, person who had an infarction of the LAD, left anterior descending artery? You brought that patient in 2 weeks ago to the hospital because they had a V1, V2, V3, V4 ST segment elevation. They did good. They survived the anterior wall infarct, which carries an 80% mortality. And with that, with that 80% mortality, you happen to have your patient survive. But they formed what they call a clot because the infarction took out the whole wall itself. The clot stabilizes the wall. If the left ventricular wall infarcts completely, it blows open, you have a ventricular aneurysm, and of course the patient dies right there. So you form this huge clot. That clot is called a mural clot, just like a mural that covers a wall. A mural is a full thickness wall clot. And once that clot breaks loose, or parts of that clot break loose, you can also get a superior mesenteric artery syndrome, a stroke. And this would be an example of a patient that could be in sinus rhythm, who all of a sudden has this abdominal pain, this so-called pain out of proportion to findings. So you have to be thinking about mural thrombi. So in your history, if you throw the 4-lead at them and you say, hey, you're in atrial fibrillation, game over, you know, I've got my risk factors, fine and dandy, you're there. You made the diagnosis easy, you made it clean, you get the patient in the hospital, and then we take it from there, and hopefully you don't blow the diagnosis in the air. But the patient comes in sinus rhythm, you cannot let your laurels down until you start asking questions. Have you had a heart attack lately? Yeah, I had a heart attack about a year ago. Where was it? It was in the front, the anterior wall. All right, we're still back in the ball game for mesenteric ischemia. Valvular heart disease. Now, this is where you start getting patients that might be a little bit younger. You get the IV drug user who has vegetations on their mitral valve. And if you recall, the mitral is over on the left side. And so the mitral valve gets these vegetations, and you get these calcified, hardened lesions that sit on the valve that cause it to leak. So when blood is ejected from the left ventricle, the mitral valve can't hold it all. And of course, a lot of it regurgitates back into the left atrium because these valve cannot close cleanly with a good seal around it. And so subsequently you get regurgitation. Well, occasionally one of these calcifications, septic emboli, whatever it is, breaks off the valve and goes into the circulation itself and could very well end up in the superior mesenteric artery. And so this is an example of a normal sinus rhythm, again, that can cause superior mesenteric artery syndrome if you're good with the history. And the history is going to be, have you ever had a valve problem? You ever had any problems at all with your heart, structural defects or any type of valve problems? Have you had a myocardial infarction in the past? And then, of course, the obvious, are you in atrial fibrillation? Do you have atrial fibrillation? So you get the 50-year-old person who comes in who was an IV drug user for all these years, and they develop some sort of a critical stenosis, aortic stenosis, or a mitral valve stenosis and such. And you have to be acutely aware that this could very well be a mechanism for why the patient's having pain out of proportion to findings. All right, let's do this. Before I get into the treatment, let's find out if anybody's got any questions. Can you just type in a question real quick if you got something? Happy to entertain it before we get into the treatment. Now, again, this isn't going to be a long seminar today, where, as a matter of fact, we're probably going to conclude this in the next 10 minutes or so, because it's a very focused clinical diagnosis of one particular abdominal type of emergency that you can have. But the reason, again, that I'm bringing it up is because we, through the EMS and through the ER and such like that, everybody kind of missed this diagnosis as we went. Fortunately, we were able to detect it. Unfortunately, it didn't turn out good for the patient. But had we had another 30 minutes, it wouldn't make a difference. We really need to see the patient 6 hours earlier. My point being is that abdominal pains in the elderly patients with atrial fibrillation or with patients that have had valve problems or MIs in the past year or any type of structural defects in their heart, you have to be really on the alert for this, and you cannot accept their AMA without a bad conversation with them about how this could end up with your death if we do not catch this mesenteric ischemia. Older folks don't like to bother you guys. They're very proud folks and such, and sometimes they're just going to say, no, it's just nausea, vomiting, diarrhea, or nah, after you guys check me out, if you don't think anything's wrong, you know, I'll just stay home and tough it out kind of thing. This is where you're going to have to be very careful, because the older folks feel that you're as fully trained paramedics, you're given a competent medical opinion, which you are, and they're going to hang their hat on it, but more importantly, they're going to bet their life on it. And this is where you have to say, you can trust me, you can bet your life on me. Now, I'm not willing to say that as an ER doctor until I get the CT scan, angiography, and about 18,000 different blood tests back before I say, yeah, you're not having a mesenteric ischemia. So I'm not sure in the field why we would proffer to an older patient who's got nausea, vomiting, diarrhea, and abdominal pain, why we would say, yeah, go ahead and stay at home. Doesn't make any sense, certainly not from a liability standpoint. When I put on my other hat as an attorney, I can tell you this would be a freebie in court. I got you. What if I got an ER doc in court? I got him. It's a freebie. You missed all these cardinal signs. How did that happen? You know, 25th run of the day with the EMS. I'm on a 12-hour shift in the ER, and this was my 35th patient, blah, blah, blah. And the courts don't look at that. They look at each patient like that was the only patient you had for the whole damn year. And how did you blow that, you know, kind of thing. All right. Let's see, I'm looking for questions. I'm not seeing one. Am I missing it? Okie dokie. Wow. All right, treatment. Let's talk about treatment for a minute.
Hey, Dr. Frame,
Yeah.
there's a couple of questions on the right. One of them says, what type of facility should a patient suspected of this be transported to?
Now, where do you see where they, oh, is it the chats?
Yeah, they're in the chats. You click the little chat button and it'll pop up on the right of your screen.
Yeah, it didn't. That's the problem.
Okay, well, that was the first one. What type of facility should a patient suspected this be transported to?
All right, well, you got bandage stations out there. So let's, for instance, in Texas, North Texas here, you got a couple places that you don't want to bring them. Gainesville would be one, Bonham would be the other. These are places notoriously lacking anything more than just the basic Band-Aids and such like that. So I wouldn't be bringing them to small hospitals. You want to bring them to someplace that's, a trauma center would be good because you got the surgeon to come right down and see them. If you're that concerned about the patient, a surgeon has to see it immediately. So that would be the first place that I would go to if you got a local trauma center. I wouldn't call a trauma alert on it. I would just make the transport. Second, if you've got, if you're familiar with the facilities in your area and you know for a fact that they have a call schedule and they have general surgery on staff, then that would be someplace that you want to bring them. But you know, until you start getting up into level 3, level 2, level 1s, it's hit and miss out there with the level 4s and the level nothings, so-called freestanding ERs or the urgent cares and such. Level 4 is just being like the bottoms of the world, you know, kind of trashy hospitals that sit in the corner of Texas and do nothing but see sore throats all day. No surgeon on staff. You want to be careful of those places, but once a place designates itself as a level 3, it means they got a surgeon on call 24 hours a day, 7 days a week, who can respond to the hospital within 30 minutes. That is the place that you want to go. So level 3, level 2, level 1 would be all fine. So that'd be kind of facility that you go to. Jane, you're going to have to help me out because I can't see the chats.
That's okay. So all right. The second question, and actually there's 2 of them from Tad. One is, are the onset of symptoms immediate or is it a gradual worsening?
They'll be immediate.
Okay.
Yeah,
and
they're going to start getting pain as soon as that clot lodges because what happens in a blood flow? It's immediate. Immediately and cut off.
Is there any referred pain?
Generally to the back.
Generally to the back, okay. And then there was a question up above. It was about assessment we missed, and it was from Brenda, and she wanted to know, in the assessment, would you examine the legs for instance, Holman's sign?
You know, Holman's are reliable probably about half the time. If they're present, that's fun. If they're not present, doesn't mean anything. They could still have a clot. And remember, a Holman sign is because of deep vein thrombosis. What we're talking about here is arterial. And so when it comes out of the left atrium into the left ventricle and into the aorta, it's got to get through an entire capillary bed before we can get into the deep vein complex. So Holman signs, which are mostly related to the diagnosis of deep vein thrombosis in the legs, have to do with squeezing the leg or forcibly dorsiflexing the foot, which stretches the gastrocnemius and soleus, which causes pain if they have a blood clot. It's always helpful to examine the extremities because if you put your hand on the extremity, put it on the back of the calf and push the foot forward, and then feel the leg and check for pulses, you may not pick up a DVT, but in the case of where an embolus is broken loose from the heart for whatever reason, the 4 reasons we stated, if an embolus gets down into the leg, it's going to cause an arterial occlusion, which is a cut off immediately of blood flow. It's going to cause the extremity to get cool or cold, depending on where the clot lodges. And it's going to be very painful to touch anywhere along that leg. I wouldn't necessarily call it a Holman sign, though, because that's mostly exclusive to a DVT.
Okay, and Greg is having to leave. He has a call, but he asked, if you believe it's new onset, would you recommend an ACS treatment plan?
You know, nitroglycerin would help. More times than not, when these patients lodge that into their abdomen, they get vasovagal. If they're hypertensive, and you remember something, this was, or maybe I didn't bring it up, mesenteric ischemia back in the very old days was called intestinal angina, because angina was just becoming discovered in the heart as well. And they theorized that it was because of an interruption of blood flow through the artery to a specific area of the heart. Same thing with the abdomen. It was termed intestinal angina. And so when you say those words, you're implying that the arterial vasculature is spasming down or is clotted off for some reason. If the patient has a normal blood pressure and it looks like they can tolerate it, you can try a nitroglycerin tablet. Nobody will have any offense to that at all. And if there's improvement, you win. Would I follow a pure ACLS protocol? That's a good question. I don't know how to answer that. Would I put them on a nitroglycerin drip and heparinize them and all that other stuff in the emergency room? I would heparinize them for sure. Whether I go with nitroglycerin or not, I don't know. But that's a very interesting question, and I promise you I'll do some research on it to see if an ACS protocol would help. I can tell you the current treatment modes for mesenteric ischemia is IV fluids, pain medications, and getting the patient into the hospital as soon as possible.
And Brenda asked about aspirin.
Yes, I'd give aspirin. Yeah.
Okay, that's all the questions I got for the moment.
All right. All right, let's see now. Let's see if we can figure out what this chat thing is all about. All right, I'm never going to figure it out here. All right, can you see the white screen again?
Yes, we can see it.
All right, good. All right, so 2 large bore IVs, crystalloid fluids, preferably 0.9 normal saline. If you've got LR, that's fine. I won't have any heartache over it. And you're given until the patient's blood pressure starts to stabilize. Just by going back to the initial question with the nitroglycerin ACS protocol, look, if your patient's already got contraindications for nitro, in other words, low blood pressure, then obviously that would negate that. Giving yourself or giving the patient fentanyl or morphine, well, either one of which don't really affect the blood pressure that much in low doses, but making the patient comfortable could very well arteriodilate enough where the clot can move. Further down the mesenteric artery that it moves, the less bowel is going to be involved with the infarction. And so morphine or fentanyl, more than anything else, is very, very helpful in these patients. And of course, continuous monitoring of the patient, Q5-minute blood pressures and such are going to be very, very helpful. But most importantly, it's going to be patient dependent. So I'm going to ask all of you as paramedics to say, I would give fluid bolus if this was a 40-year-old healthy athlete or something. I would give fluid boluses. But what do I do with the 78-year-old who has a history of congestive heart failure, atrial fibrillation, and previous MI, who's now having abdominal pain? Can't give her 2 liters, at least not without putting her on CPAP or even tubing her. So there's going to have to be judicious use of fluids with aggressive use of pain management, keeping an eye, of course, on the blood pressure. So that's about the best that we can do. Recognition of this condition is going to be most important. 2 questions on the National Registry exam, it helped to get those 2 questions correct. You'll find that mesenteric ischemia is still one of the top 8 medical emergencies that a patient can suffer, which results in death or increased liability. More likely than not, if you've got death, you've got increased liability. And so you don't really want to miss this condition. Most importantly, we're talking about something that's fixable here. And so you certainly don't want to be missing anything that had the ability to be fixed if it was just caught in a timely manner. All right, Jane, that brings me to the end of my conversation on this very short topic. Any other questions generated?
Anybody out there got anything else you'd like to ask Dr. Frame? I know you're all anxious to start your holiday weekend.
And then what I need from all you good folks is some ideas what you want to hear about over the next over the next couple of months. We have the medical director roundtables, which I enjoy doing very much. And I'll talk about just about anything you want to talk about. And even if it means a series of conditions or a group of events or whatever it is that you want to talk about, we can have a specific 1 hour roundtable just based on that. So make sure that you let Jay know what you'd like to hear about. I'm happy to put something together.
Ted Scarborough said he enjoyed this. Jeff Gibson said very informative. Brenda says she would appreciate specifics related to field reductions of dislocations and fractures as a lecture.
Okay.
And Elizabeth Roden said, great lecture, thank you. And Tad said he would like to know more about AAAs.
Yeah, aneurysms. Okay. Yeah. So I got fractures, dislocations, aneurysms, and we've got a couple of things to talk about. So it looks like we'll have a good schedule for the rest of the month.
Sounds good. Thank you all for coming, and have a very, very safe holiday weekend, everybody. Okay. So if all of you want to click out, Dr. Frame, if you'll hit the close recording button.
All the club.